So this session is about measuring health system resilience to help us make informed decision. So that's the basic reason for measuring. There are multiple frameworks for measuring health system resilience. We are not going to discuss all of them, but hopefully we will be providing you all the literature later on after the meeting. Let's start discussing some question on measuring health system resilience. We have a distinguished panel. Dr. Margaret Crook is the pioneer in developing a health system resilience index. Then we have Dr. Igor Linkov. He comes from an engineering background, and he is also an adjunct professor at Carnegie Mellon University. And currently he is working at US Army Engineer. He's the team lead for risk and decision science. Lastly, we have Dr. Stephanie Watson. She's the Director of Field Operation of Meyer Evaluation. So let me start with the general question, like in the previous format. One of the things which we are going to do a little differently, we will allow our panelists to talk a little bit more with some pictures, because as John has said, picture is describe, what is the phrase? Picture is more than 100,000 words? Yes. So we will use our pictures, especially for measurement. I think that's necessary. So let me put a general question, and I will ask Margaret first, and then Igor, and then Stephanie to respond. So the general question is, please provide an overview of your approach to resilience measurement, its relevance to health system learning and improvement, and what is the added value of this approach? Thank you.
Thank you so much, Anwar, and hello everyone. I'm happy to be with you. Let's see if we can, there we go, perfect. So I think measures, they come from something. They come from an understanding, a shared understanding of what construct it is that we're talking about. And I would put to you that resilience is a key attribute of a high-quality health system. So resilience itself is nested within this concept. Here before you I have a definition of what is a high-quality health system. And it is a system that is focused on people and on optimizing health. And it has three key features, all of which relate to states of calm and also health systems under crisis. First, consistently delivering quality services. And by that I mean not on Tuesdays in the capital city, but everywhere reliably where people can rely on having a service that they need. High-quality health systems are valued and trusted by people. I heard someone say earlier that systems will be the most common word. I actually think trust might be one of the most common words spoken this day today. But why is this so essential to the definition of health systems is that health systems are essentially a social contract. And that social contract is null and void if the populations do not trust. Lastly, high-quality systems are not static entities. They're not a pile of bricks. They respond to changing needs. Bendability is an essential feature of health systems and important for them to stay relevant. This means being able to respond immediately, of course, to a health shock, and to adapt service delivery to changing health needs, changing expectations, and changing technologies. So that's where resilience is nested. It's living inside a high-quality health system. But let's talk about trust, one of the key themes of today, and how it's connected with this notion of high-quality systems and resilience. In 2008, years before the latest Ebola outbreak, we asked the population in Liberia a very simple question. If you are sick, can you get the health care you need? It's a measure of confidence in health systems. Fewer than half said yes, which is very, very low by global standards. And what we further found is that the poorest and most traumatized members of the population, right, because there's a huge burden of mental trauma in those populations, were least confident in being able to get the health care that they need. Furthermore, people who were dissatisfied with health services were least likely to state confidence. And do you know what those people do? They turn to traditional providers. They avoid clinics. And maybe some of the very people who answered this question negatively are today involved in some of the acts of violence against Ebola centers. Okay. So the key point here is this isn't just an issue of perception. These people are right to distrust the health system. In the Lancet Global Health Quality Commission that I've had the privilege of chairing, we found that 8.6 million lives are lost each year from treatable conditions in low and middle income countries. 8.6 million. So health system quality is tightly linked to trust. People need to have services they value if they're going to come back and get them. So in research with government and academic colleagues in Liberia, we defined 5 components of resilient health systems. First, awareness of health needs. A system has to have an intelligence function. It's got to be aware of what health needs are, what its own assets are, and also points of weakness. The system also has to be diverse, working with all providers and providing a range of services, not 3 services favored by donors, but a range of services that people immediately value and need. The system has to be self-regulating, by which I mean it has to be able to isolate threats while continuing to perform core operations. It has to be integrated and working across sectors. We've heard a lot about that, and it's absolutely critical, including respectful and serious work with communities over time. Trust can't be demanded in crisis. It actually has to be earned in times of calm. And lastly, a system has to be adaptive in building flexibility into existing structures rather than trying to supplant them during an emergency. And so, coming to the point of measurement, that's the concepts we're trying to measure. What you see here is that we need to measure what matters and we need to measure when it matters. And I think the bulk of the critical measurement needs to happen well ahead of crisis. Many colleagues have discussed throughout the day today, in some ways, our emergency response is the part that we're good at. What we're not good at is the preventive function, is the building function, is the building of resilience. And so what you see here is that we need to be focusing on functions and not inputs, not measuring provider numbers and numbers of clinics, but rather system competence and provider knowledge and provider motivation. We need to be looking at performance in normal times, including routine sharing of health system performance with populations to convey where we're weak and where we want to improve. And lastly, we need to capture people's voice. And this includes issues like the endorsement and trust question that I just showed you as an example. We have a lot more detail about this in accompanying papers, but I think the core point that I want to raise here is that health systems, high-quality health systems, trust and resilience are inextricably bound. They are not a linear set of conditions, but they're all critically relevant, and they all have to be built up in advance and measured in advance. Thanks.
I will try to do it from there. Can you hear me? Okay, good. So it's late in the day, so I really like you to imagine yourself being in Venice 700 years ago. This is first plague epidemics, of course. And what happened within 20 years, out of China, it went to Europe, and Venice was the first place where it struck. Imagine yourself to be a public health provider in Venice, right? So I don't think they did indices or metrics or anything like that, but at any period of time, people think that they know how to deal with crises, right? And I think they've done something well, and I will come to that at the end of my presentation. But first, let me highlight several issues that are important. First, resilience should be measured as system property. I think several people already said that. And what we see here is that resilience is very different from risk. It's very different from other functions that you can call good system. It's all system, including health system, can be good, strong, and all that. But there are features that are different. So resilience starts when you fail, when despite of all preparation, you fail, and critical function of the system, whatever they are down. And you see this recovery pattern, right? That's where resilience starts. And the difference between self-sustained system is that self-sustained system likes to be stable. It likes to be functional. And in rare cases, fortunately, it collapses. And then what we need to have resilience, ability to recover and adapt. So how you deal with that? Well, we were talking about indices, metrics, dashboards. Several people already were saying about that. The problem with these approaches is that not, like Einstein, who said, not everything that, well, I deleted slide, but basically the idea is that in metrics you measure what you can and you miss what you cannot measure, and it may be not relevant. So the question is how you capture metrics, because we do have metrics and some of them are really relevant at the system level. And indices are not helping you to do that, because indices like Dow Jones, you get like whatever 100 random stocks, you combine them, and you get metrics of market performance. But then you have financial, healthcare. So depending on what you need, you may have gazillions of other indices. And depending on which country you are at, you may need different issues to be highlighted. So the way we approach it, we call it resilience matrix. We superimpose different system domains, which include physical, cyber, cognitive, social, that encapsulate trust and risk, and physical, your medical infrastructure, information, cyber infrastructure, with this temporal pattern of resilience evolution. In any system, you need to be able to prepare for a bad event. Once it happens, you need to be able to absorb. You cannot collapse completely. Then at some point, you need to recover and adapt. And then what happens is that in each of these 16 cells, you may place metrics that are relevant to how how the system prepares in physical domain. This is like, do you have enough of medical equipment? Do you have enough of ambulances? How a system absorbs stress in social domain? Are people trained to react in crisis? Do you have exercises? Are they trusting authorities? So this is trust issues that Margaret was talking about. Can you recover? Do you have flashlights or food in your houses that allows you to survive electricity blackdown? Can you adapt? Can you learn from your mistakes? So what we've done here, instead of just putting all the metrics together, we have ability to visualize them. Now, moreover, remember our esteemed chair had the problem to really figure out, is it like 100 words that was one figure, 1,000? I would say that for each of us it's a different answer. So this approach allows you to say that physical domain is 10 times more important for me than social domain. I work for Army Corps of Engineers. We build stuff. We don't care about people. Well, I'm joking, we do. But this is the idea. If my mission requires some of those or combination of those, I can do that. If in your countries you like to highlight some aspects of physical infrastructure and cyber with recovery, you can do that. So, and it's scalable. You can do it at the scale of individual houses or country level or regional. Now, so let's get back to Venice. So what they've done in Venice, right? They didn't do matrices. They didn't do indices. What they did, they created two structures. They have Lazaretto Island, where they sent people who were sick or suspicious to be sick. And it's interesting, again, how many, what was the process for them figuring out who is sick, who is not sick, and how public health professionals of the time did that. It's not just, you know, if you're sick, you go there. If you're not sick, you don't. And then I actually didn't know that, but I'm teaching in Venice over the last 5 years. They have this Lazaretto Island, and this is how it looks back, I mean quarantine. This is an island where they did quarantine. So on the bottom, so all ships coming to Venice were quarantined there. Initially it was 20 days, then they become 40 days. But imagine, it was very unpopular. Venice lived out of trade. Just sitting there for 40 days was disaster. But society there really enforced all that. And this is how it looks today. I went to that island. You can see some structure that survived. So what does it really mean? It means that Venetians intuitively disrupt disease propagation. They didn't know about disease. Actually, for 300 years, nobody knew what caused Black Death. Moreover, we don't even know now. It was paper like a couple of years ago that kind of raised concerns about like traditional view on Black Death propagation. What they've done, through protective clothes, this was first time public health professional use protective clothes, all this mask with big where they put some grasses. So they break patient-physician interaction at level of communication. Then at local level, they had Lazaretto Islands when they sent people, they separate community who is healthy from community that is sick. And then at regional level, they separate people from outside from people from inside. So they disrupt networks, right? And resilience for me is network property of the system. So I'm not going through that because my slides were removed by higher authorities. But in my current work, we apply network science to really model resilience across complex system, including epidemiology. We model spread of disease, transportation infrastructure, cyber infrastructure, and we use network science across all this complex system that allows you to really model exactly what happened with the network if you have different structure and how the networks can recombine itself. So I have a bunch of flyers with our publication, and we just published the book, pretty much everything I know about resilience, and I even ahead of time, so that's all I like to say.
Thank you, Igor. We all work in system constraints. So with that, please, Stephanie.
Thank you. And thank you very much for including measure evaluation in this event and on this panel. So the lens that we look through the health system is through data and through the systems and the processes that deliver quality data, and the use of these data to improve service delivery and health outcomes. So we start with the basic assumption that national health information systems are necessary for these processes, that these health information systems are comprised of many different data sources, with 12 common sources providing data elements for deriving comparable health indicators. And there are several components and subcomponents of this system that work together to produce data that are of quality and that are used. So the main components are the enabling environment. So this is where we have our HIS leadership and governance and the HIS management. And then there's health information generation, where we're looking at our data sources and the data management processes, the information products that are being produced, and any dissemination type exercises that are necessary. And then there's HIS performance, which is the outcome of the system, where we're looking at data quality. So this is where we're looking at the quality data that are produced and the use of those data for service delivery improvement and policy improvement. The human element is another component that underpins all of the others, and it's the foundation for HIS strengthening. And there are also contextual factors such as private health services, natural disasters, political priorities. So these are all influencing the components. So a strong HIS is one that generates data that are used that meet all health needs that have been identified. So a strong HIS should be well-defined, meaning it has clear definitions and documentation, such as a strategic plan. It should be comprehensive, that it covers all the appropriate health system functions and it represents the health services that are available in a particular context. It covers all levels of the health system, It's integrated, it's interoperable, and it contains comprehensive data sources. It should be functional, with leadership authority roles clearly defined, data collection procedures articulated, known, and practiced. And it should be adaptable, scalable, with continued human capacity needs and technological innovation recognized and planned for. And it should be resilient. That is, it should have the ability to withstand social, political, and biological crises and shocks. So then the question is, how do we know that we have a strong HIS or that we are progressing to a strong HIS? Which a key feature of the strong HIS is a resilient system. And we've developed, we at Measure Evaluation, we've developed a tool called the Stages of Continuous Improvement. And this tool measures the HIS status in 5 core domains, 12 components, and 39 subcomponents. And then they're staged. And the stages, it starts from an emerging stage or ad hoc, where there's limited experience with and understanding HIS issues in country. The next stage is repeatable. So this is where stakeholders have recognized the need for standardized processes and automated capabilities. Defined, where stakeholders have a shared knowledge and they collaborate on HIS activities. Managed, where activities are implemented and are used in established processes. And then I guess the ultimate goal that we would want to get to is an optimized system, where these systems are capable of learning, correcting, adapting, and improving. So with this tool, you can demonstrate clear progression from one measurement point or one status to another. So the added value, to add to the other, to answer the other question that was asked, is this tool is comprehensive and it includes global standards. So each country's HIS is going to be different and will have different strengthening needs. So this tool is broad enough to address all the possible HIS strengthening needs, and countries can adapt the tool as necessary in their context. And the stakeholders can use this tool and the assessment process involved with this tool to set goals. So where they don't have a goal for their HIS, they can use this tool to not only know the status as it is now, but also to set goals for where they want their HIS to be in the time that they are planning for. And it also has, within the tool and the process, for getting the results, this process is participatory. The assessment allows for key stakeholders from all levels of the health system, public, private, partners, to define their HIS, to say what HIS means in their context, to determine the goal for strengthening it, and for determining where exactly they are in the process, in their journey towards an optimized system, if that's what they wish their system to be. Thank you.
Thank you. Thank you for providing an overview of your approach. Since we all work in low and middle income countries, so I would like to ask some specific question regarding that. So under what condition this tool approach should be applied? How easy it is to use by manager, or does it require specialized training and other resources? Is this a standalone measurement or being integrated into existing health information system for creating resilient health system? Margaret?
Sure. So I think Stephanie's already outlined the critical role of routine systems for capturing key, particularly fast-moving, right, dynamic elements of the system, which I really would want to emphasize. What I see very often in many countries where I have the great honor of collaborating, with my colleagues is that we see reports, health reports that are 4 years old and they're sitting on the shelf, and that's the latest. That's the latest data that we have on the health worker situation in the country, and that's often only numbers and not really what those health workers can do with people in front of them. So I think the routine systems play an invaluable role in picking up on the dynamic, fast-moving components of the system. Having said that, there's a tension between getting data in a timely manner and overwhelming the people in those clinics who should be providing care, first and foremost, and having them collect more and more data. We know of the huge burnout in this country as data systems have advanced without sufficient attention to the, to a parsimonious and really spare design. And I think the same goes, and more so, in low-income country systems where there are no data managers. It's often the provider who's inputting these data. So what I would say is that we will need a mix of sources, which actually is where most high-income countries and even high middle-income countries have sort of settled out, right? We in this country rely on a combination of surveys, administrative data, non-health system data, vital registration. Can I just really emphasize how absolutely critical vital registration is? It's impossible to even know who's born or dies. What's our denominator without that? So I do think there'll be a mix. It will not be a neat picture. None of these indices, approaches that we're describing here can ever come from one source, which goes to the second part of your question, which is the capacity to work with those complex data and many of those sources. And one thing I am seeing in the countries where I'm working is that there's been tremendous investment in infrastructure, information infrastructure, DHIS2, and getting facilities online. And I am struck by the fact that many of those incredibly fancy tools are used by development partners, first and foremost, and not really the Ministry of Health, and not really the districts, not really the regions, who may not even be aware of their existence. But even if they were, they don't have the requisite skills, the time, or I think critically, the motivation and accountability chain to make those data pertinent, salient to them. So I think data use is got an element of skill, yes, but also an element of how does it fit into the accountability culture inside those health systems.
My area of expertise is actually looking at a system affected by threat. In this case, we're talking about health system affected by threat. Traditionally, we use tools of risk assessment to deal with that. In risk assessment, we start with threat. We try to see what are the vulnerability of the system and what is going to happen if threat acts on vulnerability, what would be the consequences. So this methodological framing often used in the context now of resilience, right? The problem is that this framing is only one part. As I said before, we like the system to function, we like to have strong system, but if they fail, we often don't have any mechanism in place to deal with that. So for me, field of resilience assessment and measurements should be evolving across multiple disciplines, similar to field of risk analysis that exists in finance, health, environment, energy, you name it. It exists. Resilience, in all of these fields, we try to reinvent the wheel, and there are no cross-field coordination. So in my work, I'm trying to really bridge this gap and see how universal approach to resilience quantification can be used across all these multiple fields. So to answer specifically the question, we are not talking about one tool, magic silver bullet that's going to solve health system issues across the world. Of course not. In risk analysis, we have gazillions of different tools at different levels. So in one of our papers, we advocate for tiered approach for resilience assessment and management, similarly to what we have in the field of risk analysis. When you start with screening level simple tools, when you sense the problem, you go to more advanced tools and the most advanced tools. It may be three-tiered analysis. You may stop in any one of them. But these tiers can be adjusted to the level of complexity of the system, level of expertise of decision makers and analysts. We can start with simple metrics. We can go to indices or matrices. We can go to network science. It all depends on specific problem that you have at hand, how much money you have, what is the level of expertise and sophistication of your team. And I guess that's my answer. It will be a tiered structure that we need.
So the tool that I described, which we lovingly call the SOSHI, is, I understand the context in which it sits, that with the health system strengthening, where it's at, there's a proliferation of tools. So this tool is applied when you want to know how strong your health information system is, and how resilient your health information system is positioned to be. So you're using this tool to set goals for your country's HIS, or to understand how strong it is, or how it is positioned to be strong. If you already have a baseline for this, tells you, if you have a baseline for your health information system, then it can tell you over a course of different applications of the tool whether or not you're making progress towards your goal. If you have moved from an emerging system to a defined system in policy compliance or enforcement, or if you've moved from defined to optimized in data exchange or workforce, this tool can tell you these things because of the detail that has been laid out in the tool. If you're thinking of data sources, this tool can also help you understand that. What it's not a good tool for is looking at, it's not a good tool for telling you the performance of the system, whether or not your system is producing quality data, or if those data are being used. That would be a different tool, a different assessment type. So it's really just, it really is telling you, are you on your way? Are you making good progress in this journey that you've begun?
Thank you all. It seems like we understand that these tools exist, but their application is another issue. So I would like to ask more about if you have applied these tools or approach, then how this can improve policy programs or research in fostering resilient health systems. And if you could give a country-specific example, that would be nice to illustrate your answer.
Yeah, so I think the tools I've been describing are not, the components are not all available yet, right? Even the concepts that we're proposing, such as making trust a central measure of health system performance, is not yet necessarily on the list, on the UHC coverage index, for example. So I think the first step, I mean, really measurement does not exist in a vacuum. We first have to have agreement on what it is that's worth measuring. Measurement takes time and effort. But assuming we were able to capture some of these key elements of competence, of endorsement, of confidence, health, all of these key measures that I think do matter, I think there are very powerful uses for them besides just noting progress, right? Tracking progress, which is not nothing. That's actually quite important for accountability and evaluation and so on. But so I think there are two ways that such measures can be used to drive change and drive the building of high-quality systems that then can respond to shocks. The first is that measures clearly stated and measures, and this is an important point, that are trusted locally, that are not imposed on the population, but that have a provenance. You know, more and more we want to know where food comes from. Well, the countries I'm working with want to know where these measures come from. Who's decided on this indicator, and is it relevant to our setting? And so those measures, if they are in fact co-produced and trusted, can be used very powerfully to stimulate competition in a sort of a constructive peer pressure, often among subnational units. And this sort of an approach has been shown to be very effective in some high-income countries, for example, Italy and UK and other places, where it isn't about naming and shaming, the worst performers, although that also has a function, by the way, some of the time. But rather to say, if this region next to yours, often it's the neighbor that motivates you the most, is able to do better on these 4 components, why is that? So I think this sort of benchmarking and competition is one important use of the measures. The other one, though, is what we in the Commission on Quality called igniting demand. One of the key features of really a lot of the research on community participation, community reaction to outbreaks, community engagement, is that communities often have partial information about how the health system works and even of their own health needs. There's information asymmetry. People in the community are not trained clinicians. So in terms of igniting, and yet they are fundamental to improvement. Why? Because they're the users. If we don't hear from them, how will a service improve? I often say that every other service sector queries their users all the time, but not healthcare, right? So I think, how do we do that? Well, first, let's let people know what do we mean by a high-quality system? What do we mean by a well-performing clinic? All right, what should they be expecting from their clinician? So there's an education component, but there's also a reporting of performance component, which can then be used together with accountability channels, because it's not just enough to give information, right? You have to have an opportunity, a mechanism for feedback that actually works. And by feedback, I don't mean those locked boxes you see in the small clinics all over the world that no one has keys to. And even if they did, they wouldn't know what to do with those responses. I'm talking about an accountability chain. So those communities, I think, can then assume a much more powerful role in shaping and improving systems. And just one example, you asked for an example that really struck me in our work in Liberia. And this is during crisis. And as you hopefully recall, I really want to emphasize that really the hard work has to happen long before crisis, okay? But you can't sprinkle, resilience or community trust on afterwards like a condiment. But in Liberia, one of the very excellent reactions that happened after the initial community resistance, this is at the beginning of the last outbreak, there were sort of sociologists brought in and social scientists brought in to understand why the population was resisting coming for diagnosis, for example. And one of the things that they did is they involved the community in measurement. People were underemployed, everything stopped, the economy stopped. So what did they do? They created case teams in neighborhoods outside Monrovia that were tasked with walking around their community. They were trusted by the community, right? And gathering information on symptoms. They were case finders. And those communities helped to create some of the epidemiologic data, actually, around the progression of that outbreak. So that is an example of how you and by the way, that reduces stigma, that increases use of services, that creates a bond. One of the common themes I heard is, the government never visits. They're never here with us. So why should we believe this health worker in the clinic? Why should we think they have our best interests at heart? So this close interaction, collaboration, and measurement is one mechanism for that, I think can be very powerful.
For me, this is really a financial issue, right? To make strong system, it takes a lot of investment. If I like to make system even stronger, it's exponential increase of the cost. Imagine simple experiment, right? You have a house, you're really worried about blackouts, so you invest 10,000, you buy a generator. But then, can you make it even stronger? Of course, you can buy second generator, so you buy down a little bit more risk, but it costs you another 10,000. It's still not 100% safe. You buy third generator, so you kind of see that incrementally buying down risk costs you more and more money, and cost of this additional making system stronger costs more and more. So the question is, where do you stop? At which level you say, okay, I have one generator, and now I need to invest money in thinking what happens if I have blackout and my generator fail. Can I survive with the flashlight? Should I have like 10 flashlights? Should I have a little lamp? This depends on what you do, on your critical function. So this is kind back to social side component of that. This makes sense only in relation to specific country, to specific situation, to what they used to, how they rely on healthcare. So resilience for us across multiple fields start with assessment of what is critical function that you need to sustain in your complex system to survive, And whether you even buy one generator, maybe you can survive with flashlight and you can save 10,000 and headache of maintenance of this extra generator. So that's a question that resilience can help you with, and trade-offs across hardening the system, making it stronger versus thinking, okay, if something happened, how I recover. That's argument for me, it's financial argument. How you apply it in real life, back to the question. So, of course, we have multiple examples of how we apply it in different systems. One example, actually, we did for kind of Ebola type of outbreaks that we had a few years ago. So remember, we had a few people coming to the US from affected region, and it was a really big push whether we should quarantine people or whether we should do travel restriction or what should be done. And intuitively, if you ban travel, if you put everybody in quarantine, of course you reduce risk, but it has huge cost. If you do nothing, maybe it's not good either, and it depends on the size of epidemic and strength. So in one of the papers that I will be glad to share, we model different epidemics, and we model kind of fear that you can impose on population and travel restriction, and we play with these parameters, and we show that it's optimality. Given size of epidemics, it may be optimal, just let people do whatever they do. At some point, you need to start to impose travel restriction, but it's a region where it's optimal, and you should do that, and there is a region where you shouldn't do that. So I think the response to past epidemics we had in 2014 was that, yeah, it was no reason to do travel restriction, but with tools like what we had, you can really justify that, because it was really hot political issues, and it was no tools that tells you whether you should ban travel, whether you should do quarantine and all that. So I guess I will stop here.
So I want to, this framework has been applied in about, maybe about 14 countries, where we've looked at the health system, the health information system, and have mapped the interventions that are currently being implemented in the country. But specific to the stages of continuous improvement, the tool was applied in Uganda earlier this year, following a request from the Ugandan Ministry of Health. And this was after an interaction that we had with them at the Open HIE meeting in Tanzania late last year. So the assessment was led by the Assistant Commissioner of Health Information Management Division at the Ministry of Health, and there were 35 key personnel that were involved in this assessment, from partners, from organizations, from the MOH at different levels of the system. And they established what their HIS means. So they defined what their HIS means, and this was established from other work that they had done, starting with their HIS strategy in 2018, but also other assessments that had been done to their system. And they defined their system as including population-based data sources, census, their universal health coverage, vital registration, and other surveys that they might be getting data from. And they also include their institutional-based data sources, which are some aggregated service delivery data systems, and some of these systems include HR data. So the workshop took place over 2 days, looking at all of the components in the stages of continuous improvement. And then through a prioritization process, they came up with 5 areas that they want to really focus on over the next few years, and which will be the focus of their HIS strategy. So they will be focusing on HIS strategy, strategic planning, leadership, coordination, HIS competencies, HIS workforce, their master facility list, and data management, so looking at data quality assurance processes. So the intention is to include these findings from the tool in their strategy, and they're beginning to look at their strategy, I think, about mid-year this year. And they have already said that they want to do a second measurement using this tool somewhere probably next year to see if what sort of progress has been made.
Thank you. It seems to me like this is a very diverse group, and what we are hearing is that the tools are available, their applications are challenging. At the same time, Meyer Evaluation has developed a tool in terms of synthesizing all different information system, but there is with the discussion from the earlier sessions and from our esteemed colleague who are measuring resilience, it seems like we need to do better in measuring resilience. So with that summary, I would like to open it to everybody to ask questions.
There's got to be a question.
Sorry, I just didn't know if I could go twice, so I waited my turn. Again, Wanda Jaskowitz with USAID HRH 2030 program in Chemonics. Margaret, I was really struck by what you were saying about, obviously it's about data use. I mean, we can have the data, but if we're not using it in the right way. And you mentioned it's about the accountability system and it's all about motivation, which I wholeheartedly agree. I'm curious from you and from the others, what examples do you have of how you were able in countries to increase those motivation systems, increase accountability systems, so that people were more likely to use the data? Thank you.
We don't have enough time, so just start answering.
Okay, thank you. Yeah, so I don't think, I think the motivation comes not so much from the data, because often there are data available, but really from the sort of culture and accountability in the health system that's there underlying, right? The data is really a tool to measure something that you already care about. There's plenty of data out there. We only tune in to those elements that mean something to us. That's human nature. And I think what we have, you asked for an example of how we can use it for good. I will give an example of how I think we've used it to confuse and perhaps obfuscate, which I think, unfortunately, there are more examples of that on a systematic basis. And that is that we have been working with many countries and creating many, many indicators of very simple linear inputs into systems, which have given countries the sense that they're making tremendous progress in their health system, that their health system performance is improving year on year. And I think that the elements of health system programs are improving, and I certainly don't want to be, completely negative about that. But what we're seeing is this situation in which we have plateauing health status, right? Plateauing health outcomes, particularly in conditions that have been rapidly improving and now they're sort of static. At the same time, we have new conditions coming on board, and yet the health system seems to be covering more and more people every year. And those coverage data have given the sense to policymakers, and I can cite some right now in countries where I'm working, that we're doing great. We're doing great. And they're being collected at the global level. And so some of them are starting to, in partnership with other countries, with global organizations, to start to look under the hood and say what's actually going on in the health system. So I just want us to remember that data, when used consistently and sort of shoulder to shoulder with our colleagues in countries, can be very, very powerful. So we better choose well what it is we're looking at.
I would have another take on that. We have illusion that we have a lot of data related to resilience. In fact, we have very little data. We have a lot of data related to risk. We have a lot of data related to threat. But resilience is about recovery. This is how Oxford Dictionary defines it. How many measurements we have, how fast you can recover from incident in your hospital? How many hours, how many days? How much time do you need to, if you get the patient, how much time do you need to get him recover, her? We don't have this temporal data that would really tell you how quickly you can recover. And this is really core of what resilience is. So with that said, we have many integrated metrics that kind of can connect to that. And I think that's what Margaret did in her papers, and that's what you do. But how to use them, how to make it more valuable, I think it's chicken and egg issue. For me, we need to define the framework, how we would utilize this type of data, and then you can encourage community to collect this data. And I see a crucial role of OECD, WHO, and other international bodies that can work across multiple governments, can develop these framing tools, and then hopefully we'll be able to collect this data and populate the tools with relevant data.
So there's been a lot of effort that has gone into the collection of data over the last decade or more. Especially given the influx of investment into a lot of our global programs. And so people I see this wave of people first trying to get a handle on what should I collect, and then having this wave of now I have it, what do I do with it? And in some countries are doing much better at that than others. Some people are still grappling with what should I collect, and some people have an enormous amount of data, and they're just trying to figure out what to do with it. In 2 countries where we have had quite a bit of engagement, what we found in those countries were that people were regularly looking at their data. They were meeting monthly, they were meeting quarterly, and they were looking at their program data. And they were making, interpreting their data and trying to figure out what the next steps were. Did something happen after they've interpreted their data? Is there a way to know whether or not that interpretation of data led to very specific decisions around data, around service delivery? That's a very hard thing to document. But to your question of how to get people motivated, there are people, it's very different across countries. There are people who are very motivated. They have the habit. If you ask them, they don't know where they got the habit from, but it's been there for a while. So I think it's where the countries are in their process, and some of them have just started their process, and they are just starting along this journey, and they have a very long way to go. And so it's the motivations are different because of where people are at their different stages in their health information systems.
Hi, my name is Mark Rasmussen, and I've been working on the USAID Preparedness and Response Project at DAI. And we've been working with a number of countries on establishing One Health coordinating mechanisms. And one of the main things those platforms are interested in is integrating with the health information system animal health and environment health, particularly surveillance. And so I just wanted to ask you kind of how that challenge applies in some of the countries and the systems where you're working.
I think that question, I'll take that question. So those platforms are very, very important. I think somebody this morning or this afternoon talked about coordination mechanisms, and in some cases, these are not, the sexy parts of the work, pulling people together to have these very long conversations that are very, very important, very useful conversations. But when we're talking about pulling together 3 or 4 ministries of health that probably never or don't traditionally work together, these platforms, these coordinating mechanisms, especially around the global health security agenda and One Health, are absolutely invaluable. And these are where countries find out, for example, Mali, that they were collecting data on, I think it was 30-something human and zoonotic diseases that they did not need to collect. And they had a conversation and they now collect 12. Or these are the platforms where folks in Burkina Faso are coming to grips with the fact that there are 81 different information systems alone in the Ministry of Health. And that that those systems, some of them electronic, some of them paper-based, are having to integrate and having to collaborate with paper-based systems in another ministry. So these platforms and these bringing together of stakeholders are absolutely invaluable in putting forward and having the conversations that people need to have in order to make the decisions they need to make, in order to exchange information, in order to bring together all the players that are needed, and to also recognize who's not at the table when they're having these conversations. So yes, thank you for that question. It's absolutely invaluable.
There is a dark side to that as well, of course. This is one of examples of what it's called smart system, when we try to integrate cyber physical information together. We have Industry 4.0, for those of you in Europe. We have smart cities. So basically what we do, we have information system in charge of physical environment. And it works really well when everything is good, but Florida was without electricity for like a week last fall. Because why? Because they implemented smart grid, and smart grid works perfectly fine before you get in crisis. When you get in crisis, you need to reconstruct the whole information infrastructure before you can deliver electricity. And if you don't do it with resilience in mind, it may backfire. So if One Health is just about information integration, that's fine. But if it's going to drive in a smart way crucial system, you really need to think about resilience on top of that. So we like to be smart and resilient at the same time, and again, it's trade-offs. How much of efficiency you're buying for resilience.
Any more questions?
The third time, Nazar Qureshi, USAID, Office of Health Systems. I wanted to know how much interaction there has been between the practitioners and academics who've been driving some of the progress in measurement and data use at the community level, whether it's context, empowerment agency, social capital, quality from a community perspective, all of those pieces, plus the thinking around where the gaps are in measurement at the community level tied to sort of some of the resilience thinking. How much interaction is there between the communities and the dialogue around both progress and gaps as it pertains to performance, quality, as well as context and people's agency?
We have huge efforts related to community resilience in the context of natural disasters. I think NIST has a Center for Community Resilience. DHS has similar program. Army now has Community Resilience Initiative. So it's happening. Again, it's more like government, academia, practitioners working on that. I cannot say that they really deal with resilience. Most of what is happening, again, is dealing with risk and kind of making obvious decisions about how to manage disasters, but at least we are starting. I'm not sure what's happening in health side. Maybe, Margaret.
Yeah. I mean, that's an excellent question. The framework on resilient health systems that we developed was done actually through extensive qualitative work with communities, but actually mostly, to your question, with providers and health system folks. What we Having said that, all of the research that really led to that thinking came from communities, understanding populations, and that was both qualitative and quantitative research. The kinds of data that I shared with you on trust, for example, was formative for the development of the framework. So I do think it's critical. You know, we can't design systems in a vacuum for some idealized user, right? We don't know what people need if we don't ask. We don't know what people will trust if we don't co-develop things with them. So I do think it's so fundamental. I also think it's more said than done in reality. I think it's hard to do. As someone who just finished leading a big global commission where we invested hugely in a lot of human time in trying to find patient groups and advocacy groups and so on to join, to have their own voice within that commission, I can tell you it's a huge struggle. It's a huge piece of work. Now, we did end up with substantive input, but I think it's not to be underestimated. And the ability in hiring team members on any of these efforts that have that competence and have that ability, I think, is a critical part. And that includes inside ministries of health and inside health bureaus. These are all of the actors in the system.
I think we had a good discussion here. One of the things which we try to do in this session is to orient you with what is available and what is being done by different institutions, especially from the academia, and we hope that this dialogue will continue. It's a, as Callie said in the morning, that it's a multi-sectoral, multi-scale endeavor, and this is dialogue on the resilient health system is starting, and we hope to build more collaboration with all of you, and also on the measurement side too. Thank you.